and one of the international figures of lymphology. Welcome.
Thank you very much, dear Chairman. Lymphedema and pediatric population, how we approach. You can't imagine a family with a child having lymphedema. Not only the child suffer, but all the family members suffers. If pediatric lymphedema differs from adult lymphedema, of course, pediatric lymphedema differs in adult lymphedema in many aspects. It is commonly of primary origin, and more than 90% of cases present during infancy and during adolescence. About the prevalence, the overall population of primary lymphedema is 1.33 per thousand, and in individuals below 20 years, 1.15 per 100,000. And this is historical classification of primary lymphedema year, precox from 1 to 35 years, and third onset after through 35 years, as all of us know. Accurate diagnosis is challenging and commonly misdiagnosed, and about above 2 lymphedema clinics have been misdiagnosed as primary lymphedema, as not all infants born with limb swelling have lymphedema, but maybe many. There has been a cause of this limb swelling, as you see from left to right: caposiform hemangiosarcoma, infantile lipedema, diffuse capillary malformation with overgrowth, as it appears in the right upper limb, congenital lymphomatosis, neurofibromatosis, Klippel-Trenaunay syndrome, another caposiform hemangiosarcoma on the thigh, persistent sciatic artery and veins, and vein with varicose veins, Klippel-Trenaunay, limb hypertrophy, venous malformation, a lot of for limb swelling in infants. Diagnosis of lymphedema is often delayed, not only children and also in adults, but in primary lymphedema, the average delay reach up to 9 and 4 years. And so we still see such advanced cases in our kids. Being malformation may involve, lymphedema may involve more than one limb or body parts, groins, face, genitalia, face, limbs, may affect both limbs, 3 limbs, 4 limbs, and so on. And they may occur in isolation or with other syndromic features. This is a nice recent classification, syndromic classification of algorithm for primary lymphatic anomalies that classified primary lymphedema into isolated and syndromic. And we have about 128 syndromes of lymphedema, but we have only 32 confirmed lymphedema genes. This is Noonan syndrome, one of the syndromes we see frequently in Egypt with its characteristic facial appearance. Another chorioretinopathy syndrome. The pathophysiology of primary lymphedema differ exactly than secondary lymphedema. More than half of the cases due to hypoplasia and dysplasia, but maybe hyperplasia, mega lymphatics, failure of capillary absorption as it occur in Milroy disease. Secondary lymphedema occur in less than 10%, and mainly due to amyloidic band syndrome, uh, trauma, or recurrence. A different approach to monitoring is required, and usually we use a contralateral limb when it is healthy as a control during measuring. Treatment, not mainly, but it's exclusively CDT. And we have a main four components, actually 5 components for CD: skin care, compression, manual lymphatic drainage exercise. And compression very crucial in lymphedema at all, as we see. Stimulate lymphangian contraction, reduce inflammation, promote wound healing, and breaks down fibrotic tissue. We can use it day and night, but when the child grow and resist compression, we use it at night only. Application of compression bench by the parents can be learned easily in most cases, and always individualized for each patient. Compression soaking, we usually postpone difficulties as the patient, the child resist and need to change it frequently and so on. Manual lymphatic drainage is very important and easy to apply. The exercise is a very, very important step in CTT. And interesting, during exercise, the lymphatic flow may increase 10 to 30 folds. So there is no physical activity or spot to enjoy and to play. Very important, simple compression concentrates proteins, creating a pro-inflammatory environment. Proteins and pro-inflammatory cytokines can lead to tissue fibrosis and increase risk of infection. So successful treatment requires effective drainage of the protein-rich lymph fluids by activating the lymphatic system, which could achieved by manual lymphatic drainage and exercise. And this is the outcomes of our CTT in our patients. This is an example. This is another example. This is a third. This is a very interesting example. Presented at 9 months and the exercise, and this is after 4 years. And this is how to follow our our patient regularly. About surgery is controversial, but lymphatic construction not indicated for management of primary lymphedema, as hypoplasia not amenable to physiological procedures. And so these procedures must be prohibited. Excisional surgery should be reserved for patients with involvement of the genitalia or presence of severe disease of the extremity. So this procedures, charge procedures, is a crime when do it not in children but also in adults. So in general, operation for lymphedema are not indicated under 18 years. So we postpone at the age of, when presented after age of 20, we can do liposuction for such patient. And this young guy who is, I can leave it with this image. Okay, that's, we finished, yes. Okay. Okay. Okay, no problem. For this, for lymphedema, please don't perform routine genetic testing lymphosonography without dedicated lymphovascular expertise. Please don't restrict physical activities associated with daily life. Please don't use diuretics to treat lymphedema. Please don't do reconstructive surgery in patients with primary lymphedema. In general, operations for lymphedema are not indicated for patients under the age of 18 years. Please don't fail to follow up your patient and apologize for.
Thank you. Thank you, Professor Mesbah. We will postpone the discussion till the end of the session, please. Now, can I call Professor Mahmoud Mawad? He is Professor of Vascular Surgery at Al-Azhar University in Damietta. Please, he will give a talk about thoracoscopic versus local sympathectomy in children.